Thank you, Annika, and a huge thank you to both Health Education England and the UK Pharmacogenetics and Stratified Medicine Network for putting on this event today and for providing the opportunity for you to consider pharmacogenomics and the education and training requirements that are needed to support that. I'm really delighted to be here, and I'm going to be here as much as I can today, but I may be coming and going. I'm going to start by just setting out some information about the 100,000 Genomes project, although Mark Caulfield is going to follow me, who's the Chief Scientist at Genomics England, who will talk in a bit more detail about the project and particularly some of the findings. I'm then going to talk through the NHS Genomic Medicine Service and then where we are in terms of personalised medicine and considering the adoption of pharmacogenomics for the NHS in England. So this just summarises the 100,000 Genomes project, and the reason why this is really important is the 100,000 Genomes project, which was launched in 2012 following the London Olympics and announced by David Cameron, the then Prime Minister, was to essentially introduce whole genome sequencing into the NHS, but at the same time ensure that we continued for the UK to be the leader in genomics research. What the principles of the project were established on was that whole genome sequencing, so looking at all those 3 billion letters, would extend the current diagnostic scope within the NHS, where currently it was only looking at about 1% of the whole genome in the form of whole exome sequencing. But as part of the project and providing 100,000 samples for 100,000 sequences, recruitment was part of that routine care with validation and feedback into the NHS for actionability in patients. And part of this was that participants consented to share their data, including their de-identified data for R&D and industry use and longitudinal access, but that importantly it's established a model for transformational change. In NHS England we established 13 NHS Genomic Medicine Centres that covered the whole of the population in England that the NHS serves. And so, as part of the project, the NHS Genomic Medicine Centres consented patients, provided samples and clinical data, and through the consent of patients, enabled longitudinal data to be poured via NHS Digital. Genomics England established a biorepository of samples that were collected and samples that need for sequencing, and then established an NHS sequencing centre in conjunction with Illumina. And then importantly, they established an infrastructure for data that created a national genomic research database that could be accessed by researchers, but also by industry through the Discovery Forum. At the end, though, of the sequencing journey, and within Genomics England, a new analytical pipeline was developed to be able to analyse the genome, and for that genome result to be fed back to NHS laboratories for validation before feeding back to clinicians. So we've been on a journey in the NHS since we announced the first Genomic Medicine Centre in 2014, with the first recruitment being in March 15. At the end of December, we concluded the recruitment to the project in totality, having ceased recruitment to the rare disease arm in September. And you can see that in August 15 was the first cancer patient recruited, but a lot of work had to happen to establish the right environment for cancer patients before we really started to collect samples towards the back end of 2016. So in 2019-20, there will be ongoing return of results. And this actually sets out why this is important in terms of the context of the discussion today. First of all, there's an ongoing set of activities related to validation and reporting of findings from the primary diagnostic reason that the patient was entered into the study. And some of that requires targeted testing and much more functional analyses to enable the actionability within individual patients to be determined. Return of results to participants is a multi-professional process, and it requires a large number of people within the multidisciplinary team to deliver this. As we move into the autumn of this year, as part of the project activities, there will be feedback of additional look-for findings, so other findings that may be inherited that weren't part of the original primary diagnosis that the patient was entered in terms of their eligibility. But there will also be pharmacogenomic profiles returned, which Mark, I'm sure, is going to talk about in more detail. Both of those, because of the extent of the pharmacogenomic profiling that will be presented back to the NHS, requires us to look at the impact on services in terms of what this means, who's going to manage it, where is the data going to be kept, and what is the messaging to patients. So this will be happening from the autumn, and alongside this there will be an evaluation of the impact on NHS services and what needs to be put in place so that every patient who has a pharmacogenomic profile has the appropriate support and the appropriate action is taken. So that's not a light undertaking for the NHS. What the 100,000 Genomes project, though, did, and through the NHS contribution to that project and the establishment of the NHS Genomic Medicine Centres, it enabled for the project the submission of over 106,000 samples. So the NHS did much better than the commitment we originally made of 90,000. As you can see, over 70,000 of those were in rare disease, so index cases and family members, as well as 35,000 just over in cancer. So that represents 2 genomes that have been sequenced for an individual patient with cancer, one for the germline and the second for the tumour sequence. But this slide really summarises everything that's happened. And the reason I'm putting this in here today is to show we do have an infrastructure for implementing pharmacogenomics, even though we haven't really tested this at scale. So we've had over 5,000 staff leading the change. We've had new ways of working across organisational boundaries because some 100 hospital trusts were involved in the project, and many more were involved through outreach clinics. But it was led through a single organisation working with other local delivery partners. And this will be crucial in terms of thinking about the systematic implementation of pharmacogenomics. It brought together thousands of services. It established genomic multidisciplinary teams for rare disease and cancer. And I think we still have to work through, in terms of the pharmacogenomic profiles that we've returned, how those multidisciplinary teams need to change to reflect the findings that will come back. So, for example, I expect that pharmacists will need to be part of these MDTs when these profiles are looked at. And indeed, if there are any clinical pharmacologists still left in the system, I'm looking at Mark and Mania, then they would, of course, need to be engaged. But part of this will also be about how do we reach into primary care, so that primary care are involved in understanding what this means, or is there another way of doing this? We've had a real richness of clinical data, so we can actually, through the Genomics England database, and I think, Mark, we haven't discussed this, but we have an opportunity to go back and see if retrospectively we can understand the adverse drug reactions that some patients may have had when we know what their pharmacogenomic profile is and if there are variants in actionable genes. There's been the creation of a clinical leadership infrastructure, which is important as we roll things out. So over here, through the project, we've had a whole NHS approach to embedding mainstreaming, but there's much more we need to do, and a lot more if we are going to introduce pharmacogenomics, whether that's in a limited scale, whether it's in the scale that may be fed back as part of the 100,000 Genomes project, or anything in between. We've enabled the building of evidence, and that continues. There's been this integral alignment between clinical care and research, and I think that relationship in terms of industry, and particularly the pharmaceutical industry, in relation to pharmacogenomics specifically, is only emerging. We've now got key elements of the informatics infrastructure, but it's still not all there, and we've established new clinical pathways. So this is how the NHS harnessed the project to shape the future of genomics in the NHS. It made, and so one of the things that I did is to make both the clinical diagnostic case on the basis of an increased diagnostic rate and actionability in terms of the primary diagnosis for the use of whole genome sequencing in routine care, but also along behind that establish the economic case for whole genome sequencing. And we secured new funding for genomics, whole genome sequencing and non-whole genome sequencing, such that there will be a tripling of the investment in genomics in the NHS over the next few years. We established the principles for new models of care focused on a consolidation of our laboratory infrastructure and on clinical services. We established a buy-in and principles for a national approach, both to protocols, standards and scrutiny, including the establishment of a mandated National Genomic Test Directory. It highlighted lots of issues around cancer that we need to tackle and will be tackled as part of additional investment from the NHS long-term plan. But it highlighted if we're going to do this, and we're going to do this for patient benefit, we really have to have local level coordination and service networks. And that critically, if we get this right, in its totality, including whole genome sequencing and non-whole genome sequencing, and for example, introducing gene panel testing for pharmacogenomics, we could support improved personalisation of care, which I'm going to come back to a little bit later on. So what is it we did? In October last year, I launched the NHS Genomic Medicine Service. This came following ongoing discussions about consolidating our laboratories from around 2014 onwards, and then from the NHS contribution to the 100,000 Genomes project from 2015. So on my previous slide, what you'll recognise from this is in about 3 years or less, and in actual fact it was less, through NHS England's board, we secured the ability to introduce whole genome sequencing into routine care. So the NHS Genomic Medicine Services provides consistent, or that's the aim, is to provide consistent and equitable care for the 55 million people in the population. There was wide variation in terms of access to genomics, but there's even wider variation, Mania, and I think you'd agree, in any access to pharmacogenetic or genomic testing, whatever we want to refer to. I've already mentioned that we agreed that it would operate to common standards, specifications and protocols, but at a national level we created a new genomics unit within NHS England to oversee national planning, national contracting mechanisms and national reimbursement to the service. We've standardised genomic consent for NHS care purposes, as well as giving every patient who accesses a genomic test on the NHS the ability to participate in research for patient benefit. Part of this service is integral to delivery of an approved national test directory covering the use of all genomic technologies, DNA-based at the moment, but it will evolve into RNA-based technologies and others, and from single gene to whole genome sequencing. It will continue to populate the UK genomic knowledge base, but it will create an NHS data store with all the tests that enable us to look and enable care, the effectiveness of care, and the outcomes for individual patients. And so this will also create this ongoing database, if patients consent, of de-identified data for academic and industry-based research. And it's linked to a broader ambition in this country of 5 million genomic analyses over the next 5 years and 5 million early disease cohorts. This is the infrastructure, which I'm not going to talk through in any great detail. So that's the NHS England Genomics unit and its responsibility there, and that stretches both from strategic planning and oversight through to implementation in the NHS. So, for example, any work that we did to implement pharmacogenomics within the NHS would be supported by our service improvement and implementation team that sit in the National Centre. You can see the key elements for clinical care as the test directory, the genomic lab network, the genomic medicine centres and genomic clinical and cancer services. And this is looking from year 18-19 onwards. We will continue to work in partnership with Genomics England, who will procure on behalf of the NHS the National Whole Genome Sequencing provision that will be part of the overall diagnostic repertoire that the NHS can order against. Genomics England will provide the whole genome sequence analytics and decision support and continue through a new national genomics informatics system to support a national clinical data store as well as the de-identified research environment. But you can see at the bottom here, we recognise there's ongoing workforce development required with Health Education England. There needs to be systematic patient engagement and involvement, and this will be as true for looking at primary disease as it will be for looking at pharmacogenomics, and then ongoing relationships and supporting projects with industry and academic and international partners. And we work essentially in an ecosystem with Genomics England with clear roles and responsibilities within the future. This is the National Lab Network. And so the National Testing Network is made up of 7 genomic laboratory hubs, and they really will be delivering all the heavy lifting around the transformation for the genomic medicine service. These laboratories for the first time include cancer genomic testing, as well as rare disease genomic testing, and over time this will include pharmacogenomic testing and also any other testing we introduce for more common diseases. These 7 genomic hubs, you can see from the map where they are and what the geography is, and you can see there's a sort of funny geography going through the middle of the country that covers the West Midlands, Oxford and Wessex. The southwest covers up from the very tip of Cornwall and the Isles of Scilly through to Gloucestershire. South London covers from South London, run out of Guy's and St Thomas's through to sort of Surrey. North London stretches up into parts of Essex and incorporates West London. East Midlands and East of England has a huge area and a population of some 8 to 9 million. And then Yorks and the North East covers North Cumbria as well. So this is population-based, but working together as a national network. So their aim is to build new partnerships, to lead new ways of working, to link with much broader cancer genomic testing plans, so to be responsible for that across that region and making sure everybody has equitable access. So this would be the same approach for pharmacogenomics. There's key senior leadership within this programme, this network, and also links with the evolved genomic medicine centres and pathology services. And I'm going to come back in terms of what we're doing to ensure that we have a pharmacy network that's wrapped around this national laboratory network as we start to think about pharmacogenomics. This just summarises the test directory. So it sets out what, where, why, when and how of each of the genetic tests. It covers common cancer classes and over 300 rare disease indications. It's got a structure by technology, test name, scope, targets, genes and clinical indications. So it's quite a different way to think about ordering tests than we've had in the past. And associated with that is our ability to collect activity data and outcomes. And this will be updated annually on the basis of a review of evidence to keep pace of technological developments, including pharmacogenomics and functional genomics, so looking at Transcript Omics and the like. Why this is important, I said already that we've made the case for whole genome sequencing in the NHS as part of the future diagnostic repertoire available to our 7 genomic laboratory hubs. NHS England is committed to sequence 500,000 whole genomes over the next 5 years. The test directory identifies the range of clinical indications where this technology will be utilised. And although it's currently focused on the primary diagnosis, we will expand this to include additional look-for findings and pharmacogenomic profiles. So it's coming, is the bottom line. Those are the cancer indications, and those are the 22 rare disease indications. As the price point of whole genome sequence falls, so will our ability to increase the number of whole genomes that are sequenced. But we want to maximise the impact, whether it's whole genome sequencing, non-whole genome sequencing, polygenic risk score testing, or very single specific testing for genes. And so we want to make sure that we look at the evidence for the primary diagnosis. We address the inequalities that we've got in the current system by the current testing, improve the cancer offer, as I've said, make sure that we can identify better underdiagnosed and misdiagnosed conditions in the population, like familial hypercholesterolemia, mature onset of diabetes in the young, and, for example, BRCA testing for inherited cancer disposition. But then we also want to include predictive and personalised testing, and that will include pharmacogenomics, and then look at the use of the technologies in this population-based healthcare context to provide secondary diagnoses. So there's a real opportunity through all of these applications to think about what genes we might want to include that could help us in terms of understanding adverse drug reactions or indeed responses. This is how genomics will be mainstreamed across our clinical pathways. But what you can see from this slide is this definitely requires ongoing workforce development and upskilling and multi-professional workforce. We'll drive this through local clinical indications from these core services, but we're just standing up a national nursing programme, a national pharmacy programme to create a network across the country to support the 7 genomic laboratory hubs and what will become 7 genomic medicine centres. And also we're standing up a medical programme. To make this work and to do all the other things that slide said before, including pharmacogenomics, it's essential that we do this work, and it's essential that we mainstream it across all of those. So where are we taking this? What we know is we need to use our ability to personalise care to really drive us to think about population health as well as personalised interventions. And on the right-hand side, particularly to avoid adverse drug reactions and to better use the £17 billion that are spent on drugs in the NHS in England every year. And if you think about the figures that Mania said at the very beginning, and look at the FDA, if we had only 10% of the prescriptions in the NHS that had an associated pharmacogenomic actionable variant, that could potentially impact on £1.7 billion worth of drug spend in the NHS. In reality, it could be much bigger. But that's why we need genomics to take us into data-driven healthcare and value-based healthcare. In 2016, we launched our Improving Outcomes Through Personalised Medicine document that said, in the NHS England, our whole focus will be using genomics, other functional tests, other diagnostics, to really actively personalise care for patients, and to support the 4 Ps of personalised medicine: better prediction and prevention, a more precise and objective diagnosis, more targeted and precise personalised interventions, and a better participatory role for patients. I've mentioned already the huge potential around the current drug spend, which is rising, but we also have 1 in 15 hospital admissions and an uncharted number of trips to general practice for adverse drug reactions and other work. So the first part of personalised medicine and using genomics is really to enable us to stratify treatment. And this is just stratifying treatment in cancer, but this applies to rare disease, moving us from one-size-fits-all to much more targeted, so from anatomy to mutation to intervention. But you can see on the intervention side, what this means is we've got a lot of work to do with the drugs that are available to make sure that they can fit with the genomic mutation that we're seeing. So that intervention might be existing medicines, including biosimilars. It might be repurposed and relicensed existing medicines. It might be new drug discovery and rediscovering previous candidates. It might be targeted medicines. It might be how you use medicines to avoid adverse drug reactions or other interventions, but all based on a targeted and tailored approach in the individual. And over the next year or so, there will be a lot more work on the licensing and the relationship in this space to, for example, the cancer drugs funds, and linked to the new and emerging drugs, for example, that are available for tumour mutational burden rather than single molecular markers. So why pharmacogenomics and why now? I've mentioned the spend. What we know is that typically, if we look at all drugs that are prescribed, there's about a 30 to 50% drug efficacy. We know that 50% of drugs are not taken as they are prescribed, and there's real effectiveness issues with this one-size-fits-all, and we know the adverse drug reactions. So we've got an increased knowledge of the genomic variants responsible for drug response, or not as the case may be, or the adverse drug reaction. We've got the evaluation from the 100,000 Genomes project, which will be ongoing, that gives us really a pilot scenario that we can test and understand what's required. And we've got an NHS infrastructure now to support the implementation of pharmacogenomic testing at scale if this was going to be offered across the whole population that the NHS serves in England. So we're making the case for the introduction of pharmacogenomics in the NHS. We've had a joint NHS England and Genomics England pharmacogenomics working group of experts that I've chaired with Mark Caulfield. Mania's been actively involved, and it's been supported by Ellie MacDonald from Genomics England and Alex Pickard from NHS England, but many people in this audience are part of this group, and thank you very much to everyone. But this working group has been looking at the science and evidence base to explore what should be tested and how it could be embedded. So there's been a list of candidate gene-drug pairs developed, a scoring framework developed, 125 candidate gene-drug pairs have been scored, and a short list of 50 gene-drug pairs developed. And then cost-effective analysis has been undertaken on those shortlisted pairs. And Dyfric, who you're going to hear from later, has been really critical in doing this work. So the scoring framework, as you can see in the middle here, considered the allelic frequency, the level of clinical benefit, the drug utilisation, the level of evidence, and a number of technical considerations relating to introducing this for the population at large, with all of its diversity. Where we are is we've got a short list of 50 drug gene pairs that cover neuropsychiatric areas, cardiovascular, cancer, and others such as pain management and infection. What the cost-effective analysis demonstrated was that for the short list of gene-drug pairs, the introduction of the panel would be, so a panel of those 50 drug-gene pairs, would be cost-effective when compared with the current practice of no testing at all. The next step is, how are we going to do it? Well, these are the implementation considerations that the group of experts are working through at the moment. So looking at the panel choice, so what would that technology requirement need to be, and what's the requirement for associated HLA testing? What would be the operational requirements for laboratories, because this has to be high throughput rather than a very manual process or something that takes time. What are the priority patient populations that we should focus on, and what are the implications for the pathways? Do we know what the volume of testing would be? From the laboratory side, what are the laboratory validation requirements, because this would be new, and new within an accredited laboratory environment? What's the standard reporting structure? What's the requirements around decision support? But importantly, what are the informatics developments that would essentially introduce an alert system for pharmacogenomics in the NHS from primary care through to secondary and tertiary care? And then what are all the education and training requirements? So what you can see is all the outputs of those work streams will be used to inform our commissioning system, and this will include the cost of implementation of the service. And what we anticipate, but this won't be during 1920, is that there will be a pilot started before we would roll this out more systematically, with all the implications. So this is how we see it all fitting together in terms of personalisation and what we've got to get right. We've got to get the technology, innovation and knowledge base. We've got to align the policy, system and regulatory environment, particularly the new MHRA arrangements, but also the NICE requirements. We've got to understand the infrastructure change and the informatics and commissioning, and then the clinical change and the operating model, so that patients everywhere in the NHS in England would benefit. We're going to take an end-to-end pathway approach, and our approach to date has been very much looking across the pathway, but looking through the clinical priorities for the NHS, the opportunities for population health approaches, the variation and adverse drug reactions that we see with pharmacogenomics, including for warfarin, where we've got significant utility from next-gen diagnostic approaches and where we've got variation. And you can see from a personalised medicine approach, these are all the elements that we're looking at, that includes utility, cost effectiveness, but importantly for pharmacogenomics will be the responsiveness and turnaround time to affect a clinical decision. So just to finish then, what I've talked to you is how we're stepping up the pace of genomic medicine delivery, and pharmacogenomics will be a key part of that. And by 2025, we certainly expect that pharmacogenomics would be a part of everyday routine part of genomic medicine within the NHS. We're aligning this with the commitments in the long-term plan and with the commitments that have been set out by the Office for Life Sciences, and this will feature as part of the UK genomic healthcare strategy that's being developed and includes NHS England and Genomics England. And then finally, the story won't stop there. And I'm not going to talk this through. This is a diagram taken from Topple's book, which says, essentially, as we move into personalised care, we're going to need to create an individual picture of all different elements of an individual so that we can really personalise care. But pharmacogenomics will most definitely be in the middle of that. Thank you very much.